Okay, so we're going to get started. We have a lot to get through here, so I want to try to get through what we can. We're going to talk about cannabis and the cannabinoids with a focus on migraine and chronic pain, along with some benefits, harms, and some potential legal repercussions of using these kind of therapies. I did this talk about 4 years ago here. A lot's changed, so I've updated a lot here, and we'll try to get you up to date on the legal status and everything else that goes along with this. Here is your CME code, if you want to write that down. I'll pop that up at the end of the talk today as well. Okay, so everything we're talking about today is off-label, not FDA approved for pain, for migraine, and keep in mind, Cleveland Clinic policy prohibits physicians from recommending or being involved in medical cannabis, so it's important to keep with the policy here. But these patients are asking about this continuously. A lot of this is neurological disorders that's being treated with these therapies. So it's at least our role to have an educated discussion with patients when they ask about these types of therapies, because it is state law now. We're going to start today with a very brief whirlwind historical timeline of cannabis use leading up to the current legal landscape of cannabis, as well as legal implications of using these therapies. We'll talk about the major phytocannabinoids today, particularly THC, but we'll focus on CBD especially. You see CBD everywhere. It's being infused in pillowcases to lotions. So we'll talk about that in a little more detail. We'll talk about the terpenes a bit, and I'll talk about some strain differentiation. I'll discuss some of the evidence for cannabinoid use in pain and headache, and we'll go over some clinical use highlights and suggestions. And lastly, we'll summarize some potential harms and adverse effects of the use of cannabis. Ultimately, what I hope to do, if I can do at least one thing today, is to hopefully convert some of these preconceived images that are no doubt floating through your minds with images of a very rapidly exploding new research field for novel potential therapeutics for a variety of disorders. So the use of medical cannabis really goes back thousands of years. Ancient Chinese physicians 5,000 years ago were using these therapies for childbirth pains, for arthritis. Fast forwarding to 1839, Dr. O'Shaughnessy first introduces the Western world to the use of Indian hemp, as he called it, later known as cannabis indica. And he learned about the plant after a professorship in Calcutta, India. He was a strong advocate of its use for analgesic purposes and muscle relaxation. Through the late 19th, early 20th centuries, cannabis-based preparations were being used quite routinely. They were listed on the use dispensatory in 1845. There were several large pharmaceutical companies producing these preparations. Some of these companies, as you can see, are still in existence today, not making the preparations, obviously. And there were many prominent physicians of those times prescribing cannabis for episodic and chronic daily headache, migraine, using both acutely and preventatively. And you can recognize some of these names for the historians out there of some of these famous neurologists and physicians. This was one of the earliest publications on the use of cannabis for what sounds like chronic migraine. Dr. Mackenzie published this in 1887. And he described this headache, which was a continuous daily headache, in addition to these exacerbations of paroxysmal pain, very much sounding like chronic migraine. And he described its benefit in BID dosing of cannabis. In 1915, the father of modern medicine, Sir William Osler, described the use of cannabis for the treatment of migraine in his famous textbook of the time. And he said when treating migraine, cannabis indica is probably the most satisfactory remedy. So the history of cannabis use in headache and migraine is quite interesting and rich. Unfortunately, we have a little time to talk about history today, so we're going to fast forward to the 1930s. And a man named Harry Anslinger led the Federal Bureau of Narcotics. This later became the DEA. And he began a campaign to associate cannabis use with psychosis, addiction, violent crime, and claimed it was a drug of abuse used by minorities and low-income communities. This led to the Marijuana Tax Act of 1937, and this imposed large fines and prison time for people involved with the cannabis industry. In 1941, cannabis preparations were taken off the U.S. Pharmacopoeia, and the final nail in the coffin came with the Controlled Substances Act of 1970, and this is what changed cannabis to the Schedule I status, which it currently has remained. So the issue since that time is the DEA has refused to reschedule cannabis from its most dangerous Schedule I classification, saying there's no medicinal uses. And this has really been a hindrance to federal funding and the ability to do research to try to prove or disprove these claims of no medicinal use. And we've essentially been stuck here since that time. So the paradox here is that the US government and the Department of Health and Human Services in 2003 was awarded a patent for the use of cannabinoids as antioxidants and neuroprotectants. The FDA has now approved 3 cannabinoids for medical use. 2 of these are THC only. The most recent one is Epidiolex, which is a purified CBD from the cannabis Sativa plant. We'll talk about that later. So if you're confused about this paradox, you're not the only one. So in 1996, California becomes the first state to pass the Compassionate Use Act, and this was the first state that allowed medical marijuana laws. Since that time, this trend has grown. We're now at 33 states which have medical cannabis laws. We have 11 states that allow recreational or adult use on top of medical use. So this is something that we're all dealing with whether we like it or not, and so it's worth being educated about it because we're going to be facing it. So the issue is that despite these state laws, under the Controlled Substances Act, cannabis remains a Schedule I substance. So doctors cannot prescribe it, they can recommend it, and the First Amendment protects those conversations in the office. Interstate travel with any amount of cannabis, plant extract, or even CBD oils that contain THC greater than 0.3% violate federal law and potentially could lead to federal drug trafficking charges, as well as stiff penalties and fines. So patients and providers participating in these programs tend to get a little nervous about this, understandably. And with that in mind, in 2009, the Justice Department sent a memorandum to federal prosecutors saying, look, if these patients and physicians are following their state laws, there should be no federal prosecution. In 2013, they sent a Cole memorandum to U.S. Attorney Generals, basically reinforcing that the Justice Department would not enforce federal prosecution as long as states were following their state laws. In January of 2018, the Cole memorandum was rescinded by the Attorney General. And then April of 2018, and since that time, the president has reinforced his support for protecting legal states as long as they follow their state laws. In Ohio specifically, Ohio House Bill 529 was signed into law September of 2016, making Ohio the 25th state to legalize medical use of cannabis. Sales began recently in mid-January of this year, and there are 20 qualifying conditions for which patients can apply. And I've listed these out here. We won't go into detail, but the majority of these are things that we see across the Neurological Institute. For us, it's chronic intractable pain, but there's a variety of other disorders, and patients can petition to get things added onto this list as well. But as you can see, these are things that is a focus for many of our departments. So the Ohio Department of Commerce runs the Seed to Sale program. The Medical Board of Ohio certifies doctors to recommend cannabis for patients. And again, Cleveland Clinic prohibits this from happening for our physicians. The Ohio Pharmacy Board registers patients and caregivers. They oversee the dispensaries. And ultimately, the physician recommends a 90-day supply of cannabis in a variety of forms. And notably, cannabis can be vaporized, which we'll talk about a bit later. Smoking is prohibited, though, according to the law. So some statistics of the program as of late August. The Seed to Sale program, so there's a set number of determined licenses for each step of the process. And these numbers of approved licenses are growing from cultivators to processors to testing sites, ultimately to the dispensaries. There's about 54,000 patients in the program as of the end of July, 550 physicians with a license. And since mid-January, there's been about 22 million of sales, so not bad for 6 months or so. So let's talk about a little bit of science here. The endocannabinoid system is a system that is inherent within all of us. It's widely distributed through the central and peripheral nervous system. It plays a role in many physiological processes involved in most organ systems, and it plays a very strong role in pain pathways. It's comprised of the cannabinoid receptors and the endocannabinoids, which are the ligands for the system. The CB1 receptors are formed more centrally than peripherally. They are the most abundant G protein coupled receptor in the brain, but they're also very prevalent throughout the spine and the GI system. And they modulate a wide array of neurotransmitters, inhibitory and excitatory. The CB2 receptors are found more peripherally than centrally. They play a strong role in the immune system and the hematopoietic systems. Both of these are presynaptic G protein coupled receptors, so they are involved in retrograde signaling is their mechanism. The endocannabinoids are arachidonic acid derivatives. These are synthesized on demand, and they upregulate or downregulate presynaptic neurotransmitter release. There's two primary endocannabinoids. The first one is anandamide. This is felt to be the primary mediator of endocannabinoid signaling. It has a high affinity for CB1, greater than CB2 receptors. It's actually a partial agonist at the TRPV1, the capsaicin receptors as well. And the second one is 2-AG, which plays a little bit of a lesser role. It's a pretty equal CB1 and CB2 agonist. So how does this translate to the cannabis plant? So the phytocannabinoids are basically the endocannabinoid equivalents in the cannabis plant. They stimulate the same receptors. And cannabis contains more than 100 phytocannabinoids, about 200 terpenes, and we'll talk about those in a bit, and 540 distinct compounds across 18 different chemical classes. So there's a lot of moving parts with this. The most researched and most well-known is THC, which is what causes the cannabis psychoactive effects or the high. It has strong analgesic and anti-inflammatory effects, being 20 times more anti-inflammatory than aspirin and twice as anti-inflammatory as hydrocortisone. It's a potent antiemetic, which is why we have the two FDA-approved nausea medicines that are THC. And its primary mechanism of action is primarily, it is a partial agonist at CB1 greater than CB2 receptors, although it does hit a few other receptors as well. The half-life of THC is about 4 hours, although its metabolites are extended out to 55 hours. It's metabolized through some common CYP systems, the 3A4, 2C9, 2C19, and there's a lot of common medications that also go through these pathways. And we have two synthetic forms of THC available, dronabinol and nabilone. These are both FDA approved for chemotherapy-related nausea, vomiting, as well as AIDS-associated anorexia and weight loss. THC can be detected in the blood from a few hours up to about 2 days after a single use. Heavy users, this can extend up to about a week. Saliva, it can appear within an hour and can be detectable up to about 2 days. In the urine, after one-time use, it could be detected potentially from 1 to 2 weeks. This increases as the frequency of use increases. So when you have chronic daily users, this number can go up to 2 months or even a little past 2 months because it's stored in the adipose tissue, so it's slowly released over time. Hair tests can go up generally to about 90 days. There's some tests that can go a bit further beyond that as well. CBD or cannabidiol is the more recent cannabinoid that's gained a lot of attention and being infused in everything, it seems. You can buy this now at CVS and GNC, and the problem is that we just don't have a lot of data behind it. So the nice thing about this is it's non-intoxicating, so there's no high associated with this. There's no dependence, there's no withdrawal. It's non-sedating. Some of the early literature suggested that once you get to a certain dose, it had sedative effects, but this was more likely due to some of the terpene content, which was sedating. In November of 2017, the World Health Organization put out a statement that in humans, CBD exhibits no evidence for abuse or dependence, and there's no evidence of public health concern with pure CBD. In January of 2018, the World Anti-Doping Agency removed CBD from its list of prohibited substances, allowing athletes to use these products. It is a powerful analgesic and anti-inflammatory as well, with anti-inflammatory effects several hundred times that of aspirin in animal studies. It has minimal affinity for CB1 and CB2. Actually, it works as a negative allosteric modulator or a non-competitive CB1 antagonist, And this actually helps to neutralize some of the negative THC side effects that we'll talk about later. It has more than 65 molecular targets, greater than 80 mechanisms of action identified, and its half-life is 2 to 5 days generally for oral use, which is the most common form, and this varies with other formulations. So we can't talk about CBD without talking about Epidiolex, which is a purified cannabis-derived form of CBD from the cannabis sativa plant. This was FDA approved in June of 2018 for Lennox-Gastaut syndrome and Dravet syndrome for ages 2 and older. It's a Schedule 5 medication, and the dosing ranges from 5 to 20 milligrams per kilogram per day. The data with this showed some dose-related transaminase elevations, and this is what you often hear about this. Overall, this was about 13% in the CBD group and about 1% in placebo. However, when you look at these numbers a little closer, the vast majority of these elevations were in the highest 20 mg per kg dose, and especially in use with valproate and clobazam. Without the medications in combination, there's about 3% elevation of liver enzymes. The most common adverse effects are generally somnolence, fatigue, some GI side effects. And it's important to note that the purity of this product is about 98% CBD. So it does actually contain some trace amounts of THC and some other cannabinoids and terpenes. And it's felt that these are more likely related to some of these side effects listed above. Keep in mind that the federal limit for THC is 0.3, so it's not an insignificant amount that's in there. Metabolism is primarily through the liver, especially through the CYP3A4 and 2C19 enzymes. It acts as an enzyme inhibitor, so it's important to know that this can increase levels of certain medications, including warfarin, many common antidepressants that we use, antipsychotics, and there's certainly a longer list than this, but these are some of the more common ones that we see. So the dosing recommendations are that the dose of CBD is decreased when using strong or moderate 3A4 or 2C19 inhibitors, and the CBD dose should be increased when using strong inducers of these systems. And there's a list of other substrates that should be reduced in use with Epidiolex. So the question really comes down to, is CBD safe? And we have this rigorous safety data, which is great. But the problem is that the CBD dosing that's in Epidiolex is significantly higher than what you're finding over the counter that people are using. And also, this is not completely pure CBD. There are some traces of these other plant components in it. So there's no clear dosing threshold of what interacts with the P450 system. And this is part of the problem. It's suspected to be much higher doses than what you're typically finding in over-the-counter versions of CBD. There was TVEX studies, which is a oral mucosal spray, and they looked at doses up to 40 milligrams of CBD and found no interaction with the CYP enzymes. And this 40 milligram of doses, that or less, is pretty typical of what you're seeing over the counter being used. So is it legal? And you get this question a lot. So up until January, or up until December of 18, it was illegal. And in December of 2018, the Agricultural Improvement Act, or the Farm Bill, was passed, and this legalized the agricultural growth and use of hemp and hemp derivatives, including CBD. And just to refresh your memory, hemp is basically cannabis strains that contain 0.3% or less of THC. So this removed hemp and CBD from the Controlled Substances Act, so it's no longer an illegal substance under federal law. And in May of this year, the TSA allowed CBD products to patients could travel with these products as long as that content was less than 0.3% THC as well. In Ohio, the Senate Bill 57 was passed in July recently. This basically mimicked the federal policy that legalized agricultural growth and use of hemp and hemp derivatives, including CBD in Ohio. But it's important to know that cannabis strains and CBD oils with greater than 0.3% THC are still considered marijuana. They're illegal federally. They require a medical marijuana card for use, and it's illegal across state lines at this time with these kind of products. There's a wide variety of these products out there. This is kind of a breakdown that you'll see these divided into. So there's full spectrum CBD products. These tend to be the most popular. They're most likely to provide the entourage effects that we'll talk about in a bit. And these contain everything the cannabis plant contains, CBD, but they also have trace THC, and they also have terpenes and flavonoids and these other components. Broad spectrum products are basically full spectrum minus the trace THC. And then the newer version is the CBD isolate product, which is pure CBD isolated from the trace THC and from all other plant components. The problem is that there's no regulations of quality control with these products. There's no dosing standardization. The Farm Bill did allow the FDA to remain having authority to regulate these products coming from cannabis. And this is in the works. We are waiting to hear about these regulations. And they're certainly needed. And these are a couple examples why they're needed. This was a study looking at 84 CBD products analyzed from 31 companies. And basically 70% of these were inaccurately labeled. A lot of them had higher CBD than they advertised. Some of them had lower. 22% of these had a good amount of THC. Which is certainly going to show up in urine testing and potentially cause psychoactive effects. Another study looked at 13 CBD products from a variety of stores across Los Angeles and New Jersey. 5 of these, almost half of these, had no traceable CBD in them. 2 of them had very high THC, 3 milligrams, which is a significant dose. And then 1 of them actually had a deadly strain of E. coli in one of the gel caps. So it's a little scary what's out there that people are buying. And there are certainly some good brands, but a lot of this stuff that's out there is just, it's a gamble. So the terpenes are found in cannabis, plants, fruits, vegetables, essential oils. These are what gives cannabis and plants and vegetables their aromas, their flavors, and these are things like lavender and pine, and there's a multitude of these. Many of them have medicinal benefits, including anti-inflammatory and analgesic effects. And the key thing know about the terpenes is that they work synergistically with cannabinoids for this therapeutic synergistic effect called the entourage effects, where you tend to get more medicinal quality than any of the individual components alone. So the strains have been historically divided into 3 main categories. This is a bit of an outdated way of looking at these, but generally speaking, cannabis sativa strains were felt to be more uplifting and energetic strains, better for daytime use, higher THC, lower CBD content. Cannabis indica strains were felt to be more calming and relaxing, better for nighttime use, a bit more of a balanced THC and CBD mix. And then hemp strains were basically pure CBD, low to no THC. These are where you get your CBD oils and hemp products. The problem is that subsequent biochemical studies have shown that these classification systems correlating with these strain names often are very inaccurate in actually providing the accurate amount of CBD and THC content. So there's been a move towards a new classification system of what we call chemovars. And this is more of a scientific classification. It allows medicinal users to find a chemical profile better matching what they're looking for pharmacologically. And most strains used today are hybrid strains that are genetically being crossbred for very standardized quantity of CBD and THC and terpenes and some of the other minor cannabinoids. In countries that have been doing this for a while, such as Canada, have really gotten this down to a fine science. So these are divided into 3 main types. Type 1 is THC predominant. These are very high THC, very low CBD strains. These are intoxicating. These are more often associated with recreational use rather than medical use. Patients with terminal cancer, pain, these may be the type of patients that would use these, but generally they're felt to be more recreationally based. They're psychedelic, and they can produce physiological changes of significance with heart rate and blood pressure. But they can also provide more benefit for nausea and pain in these terminal types of conditions. Type 2 is more of a balanced THC and CBD mix. They both have relatively high THC and CBD, less than type 1, and they can be intoxicating, but much lesser degree than type 1. And they, patients may tolerate these better as far as psychedelic side effects. So type 3 is CBD predominant. which is very low THC and high CBD, low to no intoxication with these strains. And these really provide no cognitive impairment, but it is possible depending on how much THC is in these. So this is the patient that we all fear when we're talking about medical cannabis. So what is the basis between this and pain? So we know that the CB1 receptors are densely located throughout the central and peripheral nervous system pain pathways. And I've listed many of these pain pathways that we're all very familiar with. The CB2 receptors also mediate inflammation and pain. There was a study in Michigan of 350 medical marijuana patients, and they basically compared patients that were coming in to recertify. So they had been using cannabis versus patients that were first-time applicants. About 87% of these patients overall were coming in for some kind of chronic pain syndrome, which is pretty consistent with most of the registries out there. And they compared these patients, and basically the patients that were coming to recertify had significantly lower pain levels, higher mental health, and higher physical functioning compared to patients who were coming to start their therapies. There was a systematic review of 18 randomized controlled trials of cannabis for chronic non-cancer pain, and most of these are neuropathic pain and chronic musculoskeletal pain syndromes, but 83% of these were statistically significant for positive analgesic effects. The same authors did a follow-up study looking at 11 additional studies that were done since their prior publication and found that 64% of these were also statistically significant for benefit and pain. There was a systematic review of 38 RCTs in chronic pain. Again, 71% of these were statistically significant. There was an article in JAMA, another systematic review and meta-analysis looking at a wide variety of medical uses. 28 of these were in chronic pain, and they concluded there was moderate quality evidence supporting the use for chronic pain and spasticity. Another JAMA article subsequent to that looked at a variety of chronic pain syndromes, neuropathic pain, chronic pain, and MS spasticity, and they concluded that it was again useful for chronic pain, neuropathic pain, and spasticity due to MS. So what this boils down to, and there's certainly more than that, but for the sake of time, what this boils down to is the number needed to treat for pain benefit tends to be about 3.4, which is similar to some of the other chronic pain studies. So with this in mind, in 2014, the Canadian Pain Society revised their consensus statement recommending cannabinoids as a third-level therapy for chronic neuropathic pain. In 2017, the National Academies of Sciences, Engineering, and Medicine published that the use of cannabis for the treatment of pain is supported by well-controlled trials, and there's substantial evidence that it can be an effective treatment for chronic pain in adults. So what about the evidence for headache and migraine disorders? There's some interesting neurobiology here, and one thing that we've seen is that the spinal fluid of chronic migraineurs was compared with normal controls, and these patients had very low levels of anandamide, or natural endocannabinoid, high levels of CGRP, not surprisingly, and high nitric oxide levels. So this led to an ongoing theory of whether these syndromes of chronic migraine, fibromyalgia, IBS, these chronic pain syndromes, could they relate to an endocannabinoid deficiency, and this has been an ongoing theory that's been in the literature. We know that anandamide inhibits dural blood vessel dilatation from migraine triggers, such as CGRP, capsaicin, nitric oxide, and this effect is reversed when you use a cannabinoid antagonist. Anandamide modulates CGRP release by the TRPV1 pathways, and CB1 activity has been shown to suppress cortical spreading depression in animal models. CB1 activation in the brainstem inhibits dural and cutaneous evoked nociceptive trigeminal vascular responses. And interestingly, this effect is modulated by the serotonergic system. And the serotonin 1BD receptors play a role in this. And as we know, these are the tryptophan receptors. So when you block these receptors, this also inhibits the CB1 responses. So there seems to be some type of synergy between these systems. CB1 activation modulates dorsal raphe nucleus firing of serotonin in the brainstem, and it decreases the basal trigeminal nucleus tone, neuronal tone. Unfortunately, we don't have a whole lot of data to back up the use of this for headache and pain. There's a number of case reports and case series. There was a retrospective review. We'll talk about some of these. There's 2 limited prospective trials containing a control group, but not a lot at this point, unfortunately. This was one of the studies. They looked at prophylaxis in chronic migraine and chronic cluster, and they used a cannabinoid formulation of a combination of THC and CBD. And in the chronic migraine group, they compared patients with amitriptyline 25 milligrams a day for 3 months and essentially found the same result, about 40% improvement for both arms, a little bit more towards the cannabinoid group. For the chronic cluster group, they compared this with 480 milligrams of verapamil, which is a pretty standard dose, and they did this for a month, and there was no prophylactic benefit for cluster. These patients in both arms were allowed to use an acute dosing of this cannabinoid combination for flares as well. In the chronic migraine group, it decreased their pain intensity by about 44%. Chronic cluster had a similar result to this, but interestingly only if they had a history of childhood migraine. I'm not sure what to make of that. Maybe Dr. Rothner knows. This was the other study. This was a randomized, double-blind, active-controlled crossover study looking at 30 patients with a refractory medication overuse headache. They had been using daily analgesics for over 5 years, and they had failed at least 3 detoxification attempts. And they compared 2 arms. One was ibuprofen, 400 milligrams a day. The other was nabilone, 0.5 milligrams a day. And they did this for 8 weeks. And then they flipped them after a washout period. And they found that nabilone was superior in improving quality of life and reducing daily analgesic intake, pain intensity, and the level of medication dependence. And nabilone is a synthetic THC as well. This was a retrospective study looking at cannabis use in migraine, and this was a chart review of 121 adults from a couple medical marijuana specialty clinics in Colorado. The patients had been referred there by their physician for the treatment of their migraine, either acutely or preventatively. And the primary outcome of this study was looking at the mean number of migraines per month at initial versus follow-up visits. And what they found was the mean migraines per month decreased from 10.4 to 4.6, which was strongly statistically significant against a retrospective study, but interesting. And about 85% of these patients reported a decrease in their migraines per month. This was a study that I did with some Canadian researchers, and we basically sent out to about 17,000 Tilray medicinal cannabis patients an electronic survey. And Tilray is a federally licensed cannabis producer in Canada. And we had a little over 2,000 patients in the study. And basically about 25% of these patients were using for headache. And so I gave them what's called the ID migraine questionnaire. It's a validated screening tool for a quick diagnosis of migraine. And it turned out about 88% of these headache patients tested high probability for migraine. So we were trying to determine, is there specific strains that are being used for these types of disorders? And we looked at other pain disorders as well. But most of these patients preferred hybrid strains. And interestingly, it was a higher THC content that they were using with beta-caryophyllene and beta-myrcene as the predominant terpenes. We looked at substitution effect, and about 54% of these patients reported substituting cannabis for other medications. Almost 44% of those were opiate substitutions. And notably, in the chronic pain patients, about 73% of them reported substituting off opiates for cannabis. 39% substituted antidepressant, prophylactic therapy, some triptans, and so it was interesting to see that. So this has led to a discussion of whether there could be a potential opioid alternative with cannabis, and this is debatable, but there's some interesting information that goes along with it. So we know the CB1 receptors are about 10 times more concentrated than mu-opioid receptors in the brain. They co-localize with opioid receptors in many pain regions, and they sparsely populate the CP centers in the brainstem, so you don't have the respiratory depression that you get with cannabinoids, or that you get with opioids. They have been shown to enhance endogenous opioids, and there's this abundant literature growing describing this opioid-sparing effect of cannabinoids. So what many of these studies are showing is that when you combine cannabinoids with opiates, you tend to get better pain relief. You tend to get a decrease in opioid use and dose requirements, a decrease in tolerance to opiates, a decrease in withdrawal, and a rekindling of opiate analgesia after prior dosages have worn off. So there was a study here a few years ago in JAMA that looked at 13 states that had medical cannabis laws, and They found that there's a 25% decrease in mean opioid death versus states that did not have medical cannabis laws. And this trend tended to strengthen each subsequent year. So about 5 years, there was a 34% decrease in opiate death in medical cannabis states. This was a large meta-analysis where they showed 17 of 19 studies had good evidence of the synergistic effect of opioids with cannabinoids. And they found that the median effective dose, the ED50 of morphine, when combined with THC, is about 3.6 times lower than the ED50 of morphine alone. And the ED50 of codeine with THC is about 9.5 times lower than the ED50 of codeine alone. And they concluded that there was robust evidence of this opioid-sparing effect of the cannabinoids. This was another study looking at chronic pain patients that were on daily morphine or oxycodone. They added vaporized cannabis to the therapy, and on average, pain decreased by about 27% after the combination, and there was no effect on plasma opioid levels, so it doesn't seem to affect the levels of the opiates. And there's been subsequent studies essentially showing that chronic pain patients using the combination of these therapies tend to have decreased opioid use in dose requirements, improved pain and functional outcomes, improvement in quality of life, and better side effect profiles. So it's an interesting arena. So as far as dosing and clinical use, there's not much we can do here, but these are things just to be aware of because with the clinic policy. We can't be involved in this, but it's worth just at least knowing about. So classically, cannabis has been smoked, obviously not the recommended form, but this gives the fastest onset, 5 to 10 minutes, shortest duration, 2 to 4 hours. Vaporizing is a very similar pharmacokinetics. This is where the cannabis flowers heated to where cannabis vapors form, but below the point of combustion, so you're not getting the smoke and as much of the respiratory toxins. Not that it's healthy, but compared to smoking. Oral formulations have the slowest onset, 1 to 3 hours. They can last 6 to 8 hours, and these are the things that you find in these gummies and brownies and these kind of foods. There's oral mucosal formulations, and there's a branded one from the same company that makes Epidiolex called Sativa. This is a standardized tincture of cannabis of 2.7 milligrams of THC and 2.5 of CBD. But you also have this array of other cannabinoids and terpenes. It's approved in 29 countries for a variety of chronic pain syndromes, as well as MS spasticity. There's a variety of topical, rectal, IM, IV formulations. There's just not enough data to have a meaningful discussion about these at this point. So on average, medical cannabis patients tend to use, from what some of the studies show, between 1 and 3 grams a day. 2 to 4 times a day tends to be typical. But it's important to note that the use of high-dose THC strains greater than 5 grams a day suggests possible tolerance or misuse and are typically not justified. THC dosing typically is suggested to start at about 1 to 2.5 milligrams at bedtime and titrating up slowly to tolerance or effect. 5 milligram doses, patients tend to still experience benefit without excess side effects. Once you get to 10 milligrams, you tend to get side effects for most patients. 15 milligrams or more, you start getting into the psychedelic side effects. And typical cannabis cigarettes, on average, about 0.5 to 5 milligrams of THC, or, comparatively, but that can certainly be much higher with a lot of the strains that are out there today. Overall, the total THC dose should be less than 20 to 30 milligrams per day to limit adverse effects as well as tolerance, and preferably using with CBD because it helps to neutralize some of those side effects. CBD dosing is really undefined. It's variable between products. Other than the Epidiolex data, for the uses that people are using it, we just don't know. Typical over-the-counter doses are generally 5 to 60 milligrams a day or TID, and people titrate them to effect. It's suggested that higher doses are likely needed for pain and inflammation to cross the blood-brain barrier, but there's just no established dosing guidelines, and this is really what we need. They've looked at studies using 400 to 600 milligrams a day that have shown some benefit in some limited anxiety studies. Up to 800 milligrams a day have shown some benefit in psychosis. And they've done studies up to 2,500 milligrams a day in some of the epilepsy studies. So it's not entirely known what the best dosing of CBD is right now, as far as the over-the-counter versions. So general use recommendations are to start low, go slow, and try to stay as low as possible. This promotes tolerance to the THC side effects. Using the lowest dose THC that you can get away with. Using CBD and THC together is suggested because it does attenuate some of these negative THC side effects. And a 15 to 20% CBD with a less than 1% THC is generally a good starting point for these products. CBD predominant products during the daytime versus THC at night is generally the suggestion. A lot of patients are using long-acting oral formulations for chronic conditions and symptoms, and on top of that, they're stacking it with vaporized PRN for episodic exacerbation symptoms. The literature suggests avoiding driving for 4 hours after inhaling cannabis, 6 hours after ingesting it, and if there's euphoria, 8 hours is the recommendation. So let's talk about the adverse effects. The problem with adverse effects is these are widely variable, and there's a lot of variables depending on dose, the method of administration, the patient's tolerance, the strain of cannabis, the ratio of THC and CBD, the quality control. There's a lot of dirty products out there. And so many studies have been inconclusive or contradictory, but it's good to know about these. Most common side effects generally come from THC, and they're sedation, dizziness, drowsiness, impaired short-term memory, slowed reaction times, and there's a wide variety of other things depending on how high of the dose you're going. There's no documented deaths from overdose or use of THC, but you can certainly get overdose syndromes. This typically occurs with high THC products and oral dosing where it takes a while to kick in, so they keep taking more and eventually it catches up to them. And signs of this are tachycardia, confusion, panic attacks, paranoia, anxiety. There's some cardiovascular side effects also from THC predominantly, and these have been things such as tachycardia and arrhythmia, increased cardiac output, so theoretically this can lead to demand ischemia, impaired vasomotor reflexes. There's been orthostatic hypotension associated with cannabis use, supine hypertension, increased carboxyhemoglobin, which also increases myocardial oxygen demand, as well as increased catecholamine levels, which increase the cardiac output and potentially ischemia. There was a literature review of 147 cases of cannabis-associated MI. The vast majority of these were in young men, 93% men, age 42 on average, and 38% of these events occurred within 24 hours of cannabis use. 70% of these were also tobacco smokers, and there was a handful of some other cardiovascular risk factors, but interesting nonetheless to be aware of. There was a case crossover study looking at close to 4,000 patients hospitalized for MI, and the authors reported a 4.8-fold increase in MI within 1 hour of smoking cannabis. After that, there was no associated risk. But when you look at the data a little closer, only about 124 patients, so 3.2% of patients had used cannabis in the preceding year, and only 9 had smoked it in the hour before. So it dilutes the data a little bit. There was a prospective cohort looking at a little over 65,000 patients, and they looked at relative risk of MI, stroke, or all cardiovascular disease, and they found that it was not increased overall in cannabis users. There's also concerns of cerebrovascular and stroke risk, and some of the postulated mechanisms for this have been altered cerebral autoregulation. Some studies have shown increased cerebral blood flow, some have shown decreased cerebral blood flow. Reversible vasospasms or vasculitis, RCVS, and also from secondary cardiac effects from THC, such as arrhythmias and cardioembolic stroke have been postulated. So there was a literature review of 71 cases of ischemic stroke in cannabis users. Again, the majority were young men, average age of 36. 77% of these occurred within 30 minutes or during use of cannabis. 34% of these patients were also using other substances, but notably 43% of these cases presented with RCVS. There was another study looking at all reported cases of cannabis and cannabinoid neurovascular events from 1964 to November of 2016. And they found 98 cases of cannabinoid-associated stroke. 85 of these were in cannabis use. The other 13 were in synthetic cannabinoids, which unfortunately we don't have time to go over today, but 73 of these were ischemic stroke. And again, 30% of these were associated with an RCVS picture. So when they looked at these 85 cannabis-associated strokes, again, young men, average age of 33, there was a variety of other substances that were used, so it kind of clouded the picture a bit. But the majority is 86% were in chronic users. Anterior circulation was most commonly involved. But when you looked at the ischemic stroke associated with RCVS, 32% of these had RCVS, and these occurred most commonly in the posterior circulation. There's been less than 100 cases reported of this cannabis arteritis, and it looks really like thromboangiitis obliterans, and it occurs in generally young men, tobacco users, and they postulated that the co-abuse of cannabis and tobacco somehow was probably more related than just the cannabis. Virtually all of these cases were a combination of smoking tobacco with cannabis. So it, again, clouded the picture a bit. And it was postulated that perhaps arsenic was a common contaminant that was causing a vasculopathy in many of these cases. There's this cannabis hyperemesis syndrome, which is on the rise with the use of cannabis. Clinically, these patients have this cyclical nausea, vomiting. They have diffuse abdominal pain. They're taking frequent hot showers, which is pathognomonic for this disorder. And these episodes occur for 1 to 2 days. They last up to 10 days potentially, and they reoccur with exposure. These syndromes tend to occur in high dose, high THC, regular cannabis users, so chronic users. It can be confused with cyclical vomiting syndrome, but it's differentiated by the use of chronic cannabis when you get this history, as well as the fact that the patient is taking these frequent hot showers, which provides temporary relief. The etiology of this is not entirely known. It's felt to be a dysregulation of the endogenous cannabinoid system by downregulation of the CB1 receptors. In the GI tract, this has been suggested to slow gastric motility, causing hyperemesis. An interesting point here is that TRPV1 receptors interact with the endocannabinoid system, as I mentioned earlier. We know that anandamide is a partial agonist at TRPV1, which is also the capsaicin receptor, and this receptor is activated by heat. So it's been suggested that perhaps these patients are indirectly stimulating their cannabinoid system by this mechanism. The treatment is cannabis cessation. There's really no way around it. It tends to recur if they reuse. Otherwise, it's supportive management. Some studies have showed capsaicin has been some benefit to some of the areas that have been benefit, when they use the hot showers. But otherwise, antipsychotics, benzos, opiates, all these things, there's really no evidence that they're useful in this syndrome. Addiction and dependence. Cannabis is about 9% rate of addiction, and comparatively, this is lower than many other substances. When you compare to tobacco, we're talking 32%. However, in adolescents, this number jumps to 17%. And if adolescents are using daily, this jumps to 25 to 50%. Intolerance does develop much faster with high potency, high THC cannabinoids, which are quite common on the street these days. The DSM-5 recognizes 5 cannabis-associated disorders. We're not going to go through these in detail, but I'm going to touch on a couple highlights here. So cannabis use disorder is felt to affect about 3 to 4% of users. It's divided into mild, moderate, or severe criteria, and it depends on how much their use is affecting their work and function and social. And prevalence decreases with age, so this occurs most commonly in young users. Cannabis withdrawal is associated with heavy chronic use, daily or near daily use for more than a few months. It typically starts within about a day, peaks at about day 3, and it can last about 2 weeks. And there's a number of symptoms that are listed out in the criteria that you can see listed out there: irritability, nervousness, and a variety of symptoms. Use during adolescence, when the brain is pruning, rewiring, organizing itself, have shown detrimental effects. Some studies show decreased IQ with heavy use in teens to adulthood. Typically before age of 18 is the main concern. So, with all this data and inconsistency, the National Academies of Sciences, Engineering, and Medicine put out this big publication in January of 2017 called The Health Effects of Cannabis and Cannabinoids. And it was basically a rigorous review of over 10,000 studies, high quality studies, and they came up with 100 different research conclusions on cannabis. And we're obviously not going to touch on all of those, but I'm going to hit a few of them here. So some of these conclusions, they said there was conclusive or substantial evidence that cannabis or cannabinoids are effective for the treatment of chronic pain in adults, as an antiemetic in the treatment of chemotherapy-induced nausea vomiting, thus the dronabinol and nabilone medications, and for improving patient-reported MS spasticity symptoms. The objective data has kind of lagged behind that subjective data, but nonetheless, that was one of their conclusions. There's limited evidence of triggering an acute MI, according to what they came up with, or ischemic stroke or subarachnoid hemorrhage. There's no evidence to support or refute chronic use and increased risk of MI. There's moderate evidence of impairment in cognitive domains, short-term memory, attention with acute cannabis use, not surprisingly. But there's limited evidence for sustained abstinence as well as persistence of these neurocognitive symptoms long-term. Unless, of course, that's under age 18 heavy use. That's a different story. There's substantial evidence for the development of schizophrenia or other psychoses, and specifically in those at risk. And there's moderate evidence for increased symptoms of a variety of psychiatric disorders, including bipolar, depression, anxiety, suicidal ideation. There's substantial evidence for increasing the risk of motor vehicle accidents. There's been plenty of studies documenting that driving and flying studies with cannabis impair attention and time distance estimation. There's moderate evidence that there's increased risk of overdose, particularly among pediatric populations, and specifically with the edibles that look like candies and gummies and these things. And there's no or insufficient evidence for all-cause mortality or death due to cannabis overdose at this point. There's substantial evidence between maternal cannabis smoking and lower birth weight. That's been pretty well documented. Lactation, there is amount that gets into the infant and the breast milk, unknown effects, but it's recommended to not use during pregnancy or breastfeeding. So in conclusion, based on the evidence right now, the cannabis for the treatment of chronic pain in adults does have some support from well-controlled clinical trials, and there does tend to be some substantial evidence for this. This may infer potential benefit to headache disorders based on overlapping neurobiological mechanisms, but we just don't have the studies supporting that or confirming that. Many cannabinoids and terpenes have strong anti-inflammatory and analgesic properties. Knowledge of these adverse effects are important in patient selection, such as patients with cardiovascular disease, and data are ultimately needed to determine the most effective ratios of cannabinoids and terpenes and other compounds and what we call these entourage effects for not only chronic pain, but headache and other medical disorders. And this is where a lot of the science is going to really fine-tune the ratios of these cannabinoids and terpenes to target various symptoms and various disease states. And these publications go through a little more detail, the references, and then there's your CME code once again. That's it. Questions? Dr. Stevens. Cash only. But the clinic policy, we cannot partake in that at all. So it's all outside the clinic. But yeah, it's not insurance covered or anything at this point. Dr. Rothner.
It's non-motivational syndrome that is talked about in adolescents from heavy use of THC. Have you seen it?
I haven't seen it, but the literature certainly supports that, and that's really that cannabis use disorder. It sounds like, and that's part of the symptoms is no motivation and a variety of other symptoms as well, and that it kind of correlates with that. It sounds like.
And is the data on stroke strong enough for you to say that there's an increased risk?
Based on the publication that they put out in January of 17, I don't think there's enough risk, but I think it's still something that is of concern. I don't think it's fully been validated either way, but the evidence leans towards You know, with how many patients are using this and the reported strokes are so low, you know, it raises the question of how much of a risk is there. And I think it depends on the patient population and their risk factors too, though.